Welcome to Medical Field Notes, the segment where we ask our providers and healthcare professionals to share their notes from the field on topics and questions that our community wants to know about. I'm Kirsten Newlon, Director of Communications and Development, and I am here with Tarrah Harman, our Manager of Cardiopulmonary Services. Welcome, Tarrah.
Hello, thanks for having me.
Absolutely, thanks for being here. So you manage our cardiopulmonary department. Can you introduce yourself for our community and share just a little bit about what is the cardiopulmonary department? What does it do in the hospital?
Okay, so I have been here at Hillsdale for 16 years now.
Okay.
So I started out as a tech, worked my way up as a therapist while I was in school, and then kind of went up the totem pole a little bit. So I have worked in all areas of the cardiopulmonary department. So in our department, we will do pulmonary function testing. We do 6-minute walks, stress testing, exercise, PFTs or pulmonary function tests. We also have the pulmonary and cardiac rehab where we see patients, and then we do sleep studies as well. So
Okay.
yeah.
Wow, very comprehensive.
And then we see inpatients.
Of course. So, and that's really, kind of the, heart of, no pun intended, of what we do as a hospital is because your team is a part of the rapid response team.
Yes.
And obviously respiratory is one of the kind of most significant concerns throughout the inpatient journey. That's something that obviously we have CRNAs in the OR specifically to ensure airway and anesthesia and everything is going really smoothly, and even from the ER to skilled nursing and everywhere in between, respiratory is always something that's kind of at the top of our minds. So talk to me just a little bit about how your team plays such a critical role in ensuring respiratory and cardiopulmonary health for our patients.
Yeah, so we are pretty much any critical event, we're there. We're making sure we're at the head of the bed, making sure that the patient is adequately breathing, ventilating well, things like that. So we're in every critical thing. So anything that comes in through the ER, and we do see every patient that goes upstairs too. We will assess them. We also do screenings for those patients upstairs to see if they might qualify for a pulmonary function test or sleep studies. So we're seeing pretty much everyone that walks in the door.
Let's get into our topic for today, which is PFTs, as you mentioned, pulmonary function tests. So just to start out, what is a PFT and why would a patient need one?
A PFT is going to kind of help us diagnose any lung disease that the patient might have, asthma, COPD, anything like that. The main one would be COPD. So our patients that have like a smoking history, your doctor would order that, and we would do a bunch of different breathing exercises to check the lung function. So whether it's seeing how much air your lungs take in and how much air that you're putting out. So a lot of patients that have a smoking history, that air gets trapped into the lungs. So we're able to kind of see.
Break that down for me. How does that work?
So the lungs, because of smoking for so long, the lungs aren't elastic like they used to be. So they don't open and close. There's little air sacs in the lungs, and they kind of get all stretched out. So they kind of close off, so then you start air trapping and all that air gets stuck in the lungs. So with the pulmonary function test, we're able to measure, how much air is the patient bringing in, and then how much are they putting out. So, and then we can also determine how fast that they can get that air in and out too. So it kind of just gives us an idea of how bad their disease is.
Okay, so what is the test itself? What kind of occurs during the process of the test?
For the test, we do several different exercises. One is going to be kind of like a panting. It's going to check like the pressure in the airways. We do have to close the door, so some people who might be very nervous about being in closed spaces, we do have to close the door for a little bit. That's not very
So
for
when you say
patients.
close the door, do you mean like of the room?
Nope. So they sit in a box.
Okay.
So when they're sitting in the box, we'll close off the door, and then it's going to kind of measure the pressure.
But the
their
door
airways.
is clear, right?
It's a clear door. Yes.
Yeah. So it's not.
There is an
enclosed
emergency release, so they can open it if
Okay.
they're feeling uncomfortable. Sometimes we
Okay.
have had to skip that portion of the test, and we just note it for the doctor that
Okay.
some patients
Yeah.
just get very
If
anxious
there's some
while they're in there.
claustrophobia. Okay.
Yeah. Yeah.
Yeah. So there is that element, but they are just clear. I've sat in that box before,
Yeah.
so I know that it's clear all the way around.
Yes,
So it's
yes.
very kind of as low
And
stress as possible.
we work with the patient. If they're
Yeah.
nervous, we have them take their time. We'll
Yeah.
open up the door in between.
Absolutely.
There's only one portion of the test where the door is actually closed. So
Yeah.
and then the remainder of the test it stays open. So.
Okay.
But one of the things that they have to do is take a nice big deep breath in, and then they slowly blow all their air out. So we try
Okay.
to see, how many seconds it takes for them to blow all that air out. So
Okay. So you can kind of, measure the capacity of the lungs in some sense.
Yeah.
Okay.
Yep.
Okay.
Yep. So we can measure the vital capacity, their total lung volume.
Okay. So how much air they can take in.
Yep.
Okay.
Yep. And then we do a force vital capacity.
Mhm.
With the force vital, that one is really what's going to tell us like the air trapping. A lot of these patients, when they take that deep breath in, we want them to blow it out as fast and as hard as they possibly
Yeah.
can. And patients that have had a long smoking history, it can take them 15 seconds to blow all the air out. And
Okay.
it's a lot, because what happens is those air sacs just
Yeah.
completely close off, and they're pushing as hard as they can to get all that air out, but it's
Okay.
just stuck in there.
Yeah. Okay. That's starting to make sense.
But people with normal lungs, you can get that air out,
Yeah.
6 seconds or less.
Something that our new pulmonologist, Dr. Martinez, said recently on our Facebook Live with him was that the lungs are basically an external organ because even though they're inside your body, they're exposed to the elements because you're breathing in air. And, there's dust and there's all sorts of things in the air. And so I'm assuming that kind of plays a role in the development of some of these diseases. So can you talk us through a few of the diseases that you test for with a PFT and how they develop?
Yeah, so most of them are going to develop with smoking history.
Okay.
We also test for alpha-1 deficiency. So with that one, that is something that's hereditary. So it kind of can attack your lungs the same way that COPD would, but these patients are it's passed down from their family members.
Gotcha.
So with that, there is treatment for it, but we do have a test that we do while we're doing their pulmonary function. So and those types of patients will still be monitored because we want to make sure that their disease, isn't worsening. So
okay, and then how does a patient kind of get in for a PFT? Is it a regular screening or is it ordered by a doctor?
We would have to have a doctor's order.
Okay.
So your primary care pulmonologist, anyone can order it.
If they're maybe concerned about your lung function.
Yeah.
Okay.
Usually if you have any sort of tobacco use, even secondhand smoke or some sort of family history, then you would have
Is
that.
it something that is done regularly or just once?
For some patients, yes. Some patients we will see every 6 months, and then some it's a yearly pulmonary function that they have done. So.
But pretty quick.
Yeah.
And it's just breathing, so pretty painless.
Yeah. It's about we will set aside about an hour for the test.
Okay.
However, we do give a bronchodilator during it. So when we give that bronchodilator, we have to wait a period of time in between. So that kind of is what makes the test a little bit longer than normal.
So bronchodilator, can you explain what that means and what role it plays?
Yeah. So a bronchodilator is basically a medication that they will inhale, and it will. Most of them are a fast-acting bronchodilator is what you'll have for like asthma. You need that immediate release, and the patient will have like instant, not really instant, but within 5 minutes their breathing should start to improve. So
so
like
dilates
albuterol,
the lungs in some way.
What we call a rescue inhaler. So what that does is it goes into the lungs. It's going to help open up the lungs. So open up those airways because they're constricted.
Thank you, Tarrah, for sharing about PFTs. I hope that if you do need a PFT at some point, that it feels a little bit more comfortable going into it. I know that your team just creates a really great environment to make sure it's as comfortable as possible and it goes smoothly.
Yeah, thank you.
Thank you for watching Medical Field Notes. To learn more about healthcare in Hillsdale County from Hillsdale Hospital, you can visit our website at hillsdalehospital.com or our social media pages for more conversations about healthcare that are just like this. Or check out our national podcast, Rural Health Today, at ruralhealthtoday.com or wherever you get your podcasts. We'll be back next week with another installation of Medical Field Notes, but until then, stay safe, stay healthy, and remember, rural health strong.